Welcome to Healthcare is Hard, a podcast for insiders. Each episode, LRB Health's Keith Figlioli will talk to the healthcare insiders who are helping to fundamentally transform our healthcare industry.
Hey everyone, this is Tom Salemi of Device Talks. Welcome back to Healthcare is Hard, a podcast for insiders. I am here with the ultimate insider, Keith Figlioli of LRB Health. Keith, got a great guest today.
Wonderful guest. And I think this may be the first for us where we're going to be on YouTube and people are going to see the infamous Tom.
I know, I'm glad I have infamy, but I'm not famous, not like your guest, Dr. Bob Wachter. He, of course, is professor and chair of the Department of Medicine at the UCSF, but he's also a well-known leader in healthcare, thought leader, author of A Digital Doctor a decade or so ago, and now I understand he's got a new book that you talked about.
Yeah, it was interesting. We, Bob, who a lot of us have followed for many decades, recently just came out with a new book at the intersection of sort of clinical delivery and technological change through AI called A Giant Leap, How AI is going to Transform Healthcare. And he just had a lot of really good, I thought, messages in here captured. And we talk a lot about that in the discussion, let alone a lot of history. I mean, the nice talking to somebody like Bob is like, he has so much history in all of this. And, we talked in the beginning a little bit about how we all were so excited. And I can remember this as well, because I was in the middle of this. We were all excited about the electronic health record and how it was going to change everything. And then upon reflection, and that's a big part of why he wrote The Digital Doctor, which he talks about, he did 26 chapters of like how much he didn't like it. I think he wrote a chapter, I think he said chapter 27, that was a little bit more about an inflection about how this could be good. But yeah, I think there was a lot of people for years and a lot of these technology changes and transformations in healthcare that had so much hype associated with them that they were going to truly, truly transform healthcare and a little duddy or created a lot more work like we've seen with EHRs. But we also talked about the frame of reference might have been wrong, where some of these technologies truly were based of pyramid, sort of foundational technologies that then had to be built upon from there, different levels of abstraction to really unlock some of the value. And I think he talks a lot in the new book, A Giant Leap, about how AI is that and AI can be that. But I think his most provocative point in the book, which for folks that have read it or not read it, should take this away, which is it doesn't have to be the best. It just has to be better than what we have today to help change healthcare. Like, it's a simple statement and it's like, of course, but like, I think the way he wrote in the book, and we talked about a little bit, I think is dead on the money, which is and we're already seeing it. We're already seeing multiple areas and use cases where, whether it's ambient scribe, whether it's prior auth, whether it's some of the things that Epic is doing in some of their workflows, like it is already helping people. Now, are we seeing massive amounts of ROI? Like we've talked in multiple episodes here, and we keep talking about this topic on the podcast because it's everywhere. And I feel like we just got to get more and more people that are in the middle of all this to help people understand truly where we are with all this stuff. But it is getting better. It's not going to be unbelievable and great, and it's going to transform overnight. We all know this is going to take a long time. But I think his points about it's going to get better and is already starting to get better kind of really come out in the book and really come out in this discussion. And then at the end of the discussion, we spent an exorbitant amount of time, which is what I really wanted Bob for, given his point of view and how long he's been at this. But more importantly, he's a clinical leader at one of the most prominent academic medical centers in this country. Is what does this all mean to the doctor-patient relationship? So not just what's going to change at the health system level or what's going to happen at a payer, but like what's going to happen with the consumer. And, for years we've had so much and still have so much uninformed consumers. If this democratized technology gets in the hands of consumers and starts informing them more, which is what we're starting to see, and then you're seeing OpenAI make a lot of noise, Anthropic make, like a lot of people make a lot of noise. Even Microsoft came out with something, again, in terms of managing your records. What does that mean? When the patient shows up in the doctor's office and says, listen, this is what's going on with me. I've already done, we talk about the average health record in the discussion being like a Moby Dick book, 600 pages. So if someone has used AI to consolidate that down and has a point of view of what their care should be, like, what does that mean to the doctor and how do they manage all that?
No, I think is the concern though, or is there a concern that folks may be misinformed? They'll be informed, but they may be misinformed. I mean, we saw that with Dr. Google. Folks were going to be looking up their own symptoms and coming with their own recommendations. So we saw a variance of this. I agree. AI is just leagues ahead of that. And it's helped me, I mean, in some ways, with things that I've had questions about that I couldn't have gone to a doctor with. And I think it's been fairly spot on, nothing too severe. But it'll be different this time that the folks are getting the information that's correct and that will be productive?
I think it's still TBD. Some
Yeah.
of it may be correct. Some of it may be misguided because there wasn't enough data put into what got pulled through. I mean, there's so much nuance in this in my mind, but it's not just, it's a stair step problem in my head, which is, and we talk a lot to our network members about this, is first, yes, there's a one-to-one interaction problem, which is that information right or not? And second, does the patient take different steps? There was a study released, I think, last week talking about how the patient journey is already being changed, where less people trying to go to specialists after they do some of this work and going more to their primary. And Bob talks a lot, and he wrote New York Times op-ed not too long ago about, are we going to bring primary care back through all of this? Is primary care going to become a bigger thing and handle more things that specialists in a traditional way, analog way, have traditionally done? And then third, the bigger step ladder is like, what does this mean to systems? What does this mean to the front door? What does this mean to market share? What does it mean to people that don't embrace this, but others do embrace this and start redirecting care and redirecting patients and consumers a different way? Like, there's so much that starts as a real simple patient-doctor relationship issue. And is it informed information or misinformed information? But then all the other things up and down the strategy ladder, in my mind, are massive and all up for grabs.
All right. Well, there's a lot to talk about. You'll be talking about it with Dr. Bob Wachter. Again, he's professor and chair of the Department of Medicine at UCSF, and the book is A Giant Leap. So let's get your interview started.
Welcome back to the Healthcare is Hard podcast. We have another fun one today. I have admired you from afar from a long time, and I always listen to everything you usually say, and more importantly, all the books that you've written. And one of the reasons my reach out to try to get you on was we've been talking about all things, like everybody, healthcare transformation and AI. And I actually happened to pick up your new book, A Giant Leap, over the last month or so and gone through it. And I was like, oh, we got to get Bob on the podcast. So we're ecstatic to have Dr. Bob Wachter, who is the professor and chair of the Department of Medicine at UCSF, and out there talking about this great book that you just put together over the last number of years. But Bob, we're really excited to have you.
Thank you, Keith. Great to be here. And I'm also a longtime admirer, so nice to have a chance to get together.
I appreciate that. And I have a very close colleague of mine, friend of mine, mentor of mine, that actually sent me a note a week ago and said, Keith, you were quoted in Bob's book. And I said, no, I didn't know that. And then at the tail end of the book, I was like, oh, and I even showed my kids. So I want to thank you, but it was kind of a fun thing to see in your book. So fun way to start. But let's just start. You've such an incredible background and such an incredible service to healthcare, in my opinion. But it would be just great to understand sort of like, where did this start? Where did this kind of path of leading voice of patient safety, hospital medicine, transformation, technology, the intersection of all that kind of start for you?
Well, I've only come to understand my career in retrospect, and I can kind of reverse engineer a way of making it sound like it was all planned, rational, and of course it was none of that. Neither of my parents went to college. I went to Penn as an undergrad. It was right around the Watergate era. And I realized I wanted to be a doctor, but also realized I loved political science and history more than I loved organic chemistry. So I was a poli-sci major in college and really struggled with, how is that all going to sync up? And luckily, it was in an era where you were beginning to see some physicians who got interested in the system. And that is now how I define my career. It's like, what happens when a poli-sci major becomes an academic physician? I'm not going to study CRISPR or genes or whatever. I'm going to study the system. And it turns out the system is infinitely interesting, wildly complex, 20% of the GDP, $5 trillion a year, something that people care about deeply, but something that does not deliver what people want it to deliver, which is good health and good health care in a predictable, reliable way. That sort of North Star of just like trying to figure out how do you make the system work better has led me to toggle about every 7 years to a new issue that just floats my boat. And one of them, an early one, was how do we organize hospital care? And I cooked up this word called hospitalist, and it became the fastest growing specialty in history. I got then very interested in medical errors and patient safety, which was really, once I understood that the reason we commit lots of errors is that the system doesn't work very well, as opposed to doctors are bad and careless humans or nurses are, that got me super interested in that and spent a lot of time writing and thinking about patient safety. During COVID, I jumped in and I did a lot of public communication around COVID, which also seemed like the most important issue in the world. But over the last 15 years, I'd say the dominant issue for me has been tech. And I am unencumbered by knowing anything about how tech works. Like, do not ask me any engineering question. I barely know the difference between an API and an APB. But I came to believe, particularly from my work in patient safety, that the defining issue of my generation in healthcare would be how we integrate tech. 15 years ago, we all implemented electronic health records, and I thought that was going to be our savior, and found ourselves and myself kind of complaining about our EHRs and feeling like it hadn't helped things and maybe even made some things worse. I found that really interesting and wrote a book about it 10 years ago that did well. And so that's been what I've been thinking about and studying. And then the day ChatGPT came out on November 30th, 2022, I tried that and a light bulb went off. And I said, this is now going to be the issue of the next 10 years. And so I should jump in and see if I can understand it and then articulate it in a way that hopefully is helpful to other people.
And you sit in the epicenter, right? I mean, you're in your back door, you're experiencing all of this in real time. Obviously, the EHR area, not so much, but the AI era, a lot. And so, like, when you look through that book, the digital doctor era, and then thinking about the giant leap and the newest book, like, what has changed in your mind, like, in all of this? Like, what you set assumptions you had maybe when you first started that book back in the day and tied into some of the HR stuff, and then to your point about 10 years ago, then like where we are now, how do you think about things differently?
Yeah, it turns out, first of all, I agree with you with the epicenter in a couple of ways. One, I'm chair of a very large department in one of the great academic health systems in the country. So, and I'm chair of a department of medicine, which means I have everything from palliative care, geriatricians, primary care, to cardiologists and oncologists who work at least theoretically for me. And I get to see how a big health system thinks about life. I also in San Francisco, so I'm surrounded by AI companies and I advised a bunch of companies, and that's helpful to me in understanding sort of how the VC world thinks, how companies think. And I think if I didn't have that, I wouldn't get this as well. At the end of The Digital Doctor, it's, I think, chapter 27, after 26 very grumpy, kind of pissed off chapters of like, why did this go off the rails so badly? And I thought that, the HR was going to save us and was going to be the thing that was going to make care better and safer and cheaper and all that. Why? What was the problem? Chapter 27, as I've gone back and reread it, is this pretty optimistic chapter, like this is all going to work out, but the mistake in my own thinking and maybe our collective thinking was that the EHR was the answer. People come up to me after reading that and said, who was your ghostwriter for chapter 27? Because it's like this sunny, can-do chapter. And it's like, no, I think it's going to work out. The mistake was believing that the EHR was the answer. And the EHR really was the foundation. The EHR created an infrastructure, created a big filing cabinet where the data were now in digital form. So you couldn't do anything if it was on pieces of paper and charts. The data were now in digital form, but we really didn't understand that that's just the starting gun. That's not the finish. And that chapter was, I can see a world where we now figure out new ways of analyzing the data and using it to create new care models that are going to make care better, safer, less expensive, more satisfying, more accessible, more convenient. And we haven't done that yet. And in some ways, all the EHR did was A, create a filing cabinet, but B, create a huge amount of burden for clinicians, which surprised all of us because most of our tech makes our lives better. But it became an enabler of corporate control, meaning nobody could make me do anything when I was on the wards taking care of patients. When I was scribbling on pieces of paper, they would have to read it a month later and see if they could decipher my handwriting and realize, my God, you screwed up, but it's like 2 months late. Now you had a mechanism to measure, see what was going on in real time, potentially influence in real time. And to me, it was just a matter of like, when would the tech get good enough to do that? Part of that was a lot of our data is unstructured. It's in physician notes. So you needed a tech that could read unstructured data. You needed a tech that could sort of mine the literature to understand what the best care looks like. And so part of it was we were waiting for generative AI to come out. And none of us, maybe you knew, I had no idea what generative AI was and what it would look like, but we needed a tech that would reach that point. And I'd say the flip side of it, and in some ways my optimism is two things, comes from two, in some ways, discrete paths. One is the tech is really pretty spiffy and different than anything we've seen before. The second is the healthcare system is in such dire need of improvement, and everybody kind of gets that now. They sort of got it 10 years ago, but our go-to solution, the billing rules have gotten really complicated and the insurance companies are asking for prior authorizations. Okay, let's hire another 100 people to be in the billing department or the call center or the whatever. Cancer, you have a new diagnosis of cancer. It's wildly complicated. We need somebody to hold your hand as you go to see the oncologist and the infusion center and the surgeons. All right, we'll hire care navigators and coordinators. We reached a point over the last 5, 10-ish years that not only could we not afford that because all these people cost money, but we couldn't even find the people in many cases. So it's really the Venn diagram of unmeetable needs in the healthcare system, which everybody knows. And you see, all the labor disputes and the policy issues that come up because of the costs and the problems with quality and access, meeting now a technology that has these unique capabilities that the EHR didn't have. And that was the eureka moment for me. Like those two things coming together are going to create something that's really quite impressive and different than anything we've seen before.
And I think you're spot on. And I think everybody, the way I've always thought about it back in the day with EHRs, I think everybody had the frame of reference wrong, to your point. And I always tried to equate it early in my career, did a bunch of stuff outside of healthcare in the technology space, actually in the Bay Area, and got a lot of experience with travel. And when you look into some of these industries and some of their tech stacks, things like Sabre, we were thinking that, we were webifying EHR and doing a bunch of very advanced things like we're thinking about now, but we were still in the Sabre days of just kind of, to your point, putting the baseline in. So it's been an interesting journey kind of watching everybody kind of come around this time.
Can I just ask you about Sabre, Keith, for a sec? Because that, when people talk about can Epic be replaced? And the example I use is Sabre, which is you have this database that's 50 years old and nobody touches it directly anymore. There have been all these tools layered on top of it, but you still do have a database of record. And then other people say, yeah, eventually it goes away and gets replaced by something fancy in the cloud and AI and all. What do you think the lesson of Sabre, and I know you're supposed to interview me, but what do you think the lesson of Sabre means for the future of the EHR?
Yeah, to finish my logic on that I've often talked about is I don't think it goes away. I think just like Sabre today has not gone away. It is still handles millions of transactions a day because it's very foolproof. And we have a lot of areas in our technology stack that a lot of people don't like to talk about because it's not sexy, that are very high throughput transactional needs in various different industries that we have. But then you're just putting layers of abstraction on top of that. So no different when the web came out, we built a bunch of different airline websites. Then people are like, oh, well, why don't we build Orbits and Expedia that actually aggregate those in your next level of abstraction? Oh, let's build Kayak. That's the next level of abstraction. So to me, I feel like we're finally getting to your point in that era where we can start building on top of the extraction layer. Maybe a little later, we can talk a little bit about like what we think may happen in all of this in the various different technology layers. I don't know if you're there, but my view is these core transactional systems, whether it's Epic, whether it's somebody like a Workday on the GL side, they have to exist because they have to be able to, there's a big debate right now between, as you know, systems of record and systems of action and those kind of things. Yes, can somebody go and rewrite and do a bunch of stuff like that? Maybe. But I think at some point in time, you still have to run transactions through a workflow to get something done. So to me, I think it's an interesting question too, because many people.
I think we landed in the same place, coming at it from different angles. And I think there's a new question we'll probably get to, which is, AI, all these third-party tools now are competing against Epic, which is building its own and having a very hard time doing it because there's some real advantages of it having it integrated into the core system.
Yeah, and we just published something in the last 2 weeks on this, which is tying into your question, so I'll bring it up, is like if you really think about the different layers of technology, you have all these players, big players like Epic, Workday, Salesforce, what I'll call various systems that are across these health systems that are starting to become more and more hardened, in my opinion. You have a lot of energy in your backyard from OpenAI and Anthropic right now of coming in and helping to be the orchestration layer. And that is intertwined with the hyperscalers and how the hyperscalers are thinking about it. No different than what Microsoft is doing with their stack. And every health system in this country and almost every payer runs the Microsoft stack. And then you have everybody else. Then you have all the other players that are trying to get into every other piece of action on that. The point you're making, I think, is a really interesting look forward in the next kind of, we'll call it 5, 7, and it's moving so fast, maybe it's 3 to 5. Like what really takes hold here and who ends up owning what over time and controlling what, which will be interesting. And then maybe on that tangent, like when you step back in your role as the chair back to thinking about some of these things. What is your leadership message to everybody about how do you think about this intense strain, this incredible amount of change, and what should clinicians be doing in all of this?
I'd say my core message is UCSF is one of the great academic medical centers in the country, always rated in the top 10 as clinical delivery system, and certainly in the top 5 in education, usually number 1 in the country in NIH grants. And we are great. We will not be great in 5 years if we're not great at this. I just have a core belief that this is going to be the defining issue of our era. And I don't care how great you are coming into it, but if you have not figured out how to thoughtfully integrate this into your day-to-day work, you will be supplanted by others that do that. Now, healthcare is a funny animal because planted in primary care or urgent care or prevention, or how do you get your Wegovy or your Zepbound, or how do you, that I could see happening tomorrow, probably even, maybe even today. Supplanted in kidney transplants or bone marrow transplants for your leukemia, or the integration of current research into sort of cutting edge care, it's going to be pretty hard to displace the incumbents. I mean, the amount of cost that goes into creating a UCSF, a Johns Hopkins, a Harvard, a Mass General, that kind of thing, is really pretty daunting. So it comes back to another aviation example. Are these startups that are sort of nibbling at the margins of things we're not very good at and probably are achievable because they really relate to patients out there and not needing sort of super tech? Is that Southwest Airlines? Is that the disruptive innovation that we sort of give up a part of the franchise? And before we know it, a VC-funded third-party thing is offering a kidney transplant at 1/10 of our cost in some garage somewhere. I don't think so. I think the regulatory environment will prevent that. I think that the complexity of those tasks is real. Then you have a whole different set of problems, which is, okay, you still need to go to the big place to do the fancy stuff. But the basic stuff they don't do anymore. And the basic stuff is the feeder for the fancy stuff. That's how patients get to you in the first place. So you don't control it anymore. They do. And that leads to a lot of business disruption that I think is almost hard to understand. But the core answer to your question is I'm pushing our department. I'm trying to push UCSF to be great at this. Is sort of a combination of studying it, building it into our educational environment, to some extent building some tools, but more on the integration side. Like, how do we use these tools to be better at our 3 core missions, not just clinical care, but research and education? And I want to be pushing people to try these tools, use it, learn from each other, learn what others are using it for. That's my Uber message day to day.
And I would assume culturally, you would be in a place, meaning San Francisco, that people would receive that message probably better. But when you pan back and think about the healthcare system and all the different pockets around this country, is that a big thing that you're thinking about as well? Because your point about research, clinical, and education, like, it is going to impact all 3 of those vectors. And so the question is like, do you feel like that's going to be uniform, or do you feel like that's going to be really lumpy over the next number of years, given how rapid this is all going?
Well, I think the cross-vector thing is sort of a particular challenge and opportunity for big academic medical centers. I always describe our business as being a very funny business. The people who are in it don't realize, like the fish, that they're in water. But the business schools don't run businesses, and the law schools don't run a law firm. We do education research, and then we run a huge clinical delivery system, and they all cut across each other, influence each other, cross-subsidize each other. It's really pretty funky. If you're running HCA or Tenet or even Kaiser to some extent, you do some research, you may have some educational programs, but your core business is clinical. It makes life a little bit easier. There's some advantages we have from having really smart young people around too, so they compensate. But I do think that in each of those domains, like everything in life, I mean, there's no domain that's not going to be turned upside down by AI. So we've got to be thinking in the clinical world, how do we make care better, safer, less expensive using AI? That then interdigitates with the research world, because now all of a sudden we've got a massive amounts of data that we could be using for research, and the research may inform what we do clinically. For the educational environment, our train and operate in a clinical area. One of the things that came up recently here, the committees that were deciding, do we turn the switch on for scribes or AI generating a discharge summary or AI suggesting diagnoses, in the beginning had no education people on it. And then we realized, wait a second, those are profound questions about our trainees. Should they be given access to these fancy AI tools that may promote de-skilling? Or do we somehow shield them from those tools for a while, creating this sort of funky environment where their supervisor is using the tool, but they can't, or their patient's using the tool, but they can't? These are really tricky questions. So there's a lot of crosshatches between all these domains that we've got to think about in ways that if all we were was a clinical delivery system, that's hard enough. But I think it adds an interesting level of complexity for us.
I want to dive into like 3 or 4 of those things you just brought up. But with where we are, like in this moment, was like that your realization that I should write this book?
Yeah, when I wrote The Digital Doctor, it was because I was hearing everybody grumpy about their electronic health record, and all the explanations made no sense to me. This was bought by the CFO who never talked to a doctor, or Epic has no idea how clinical work is organized, or it's a big billing machine. And I said, that's probably a little bit right, not complete, or I needed to understand it better and then try to articulate it. For this book, the minute I tried ChatGPT for the first time on November 30th, 2022, I said, this is really interesting. And of course, began thinking about writing a book. My wife, who's a very accomplished author, said, you should write a book. I said, no, I don't think so. By the time I write it, there'll be 20 books on this. And the minute it comes out, it'll be out of date because we'll be on GPT-23. And then the publisher called me, and my agent called me like a month later, said, you should write a book on this. And I said, oh, what a good idea, which completely pissed my wife off. But the epiphany for me was, if I wrote a book that was going to be out of date the minute it came out, then I've written the wrong book. It really pushed me to say, what are the big cosmic issues that happen when this kind of technology enters a field like healthcare? And that drove me to sort of helicopter up one level, and I think made the writing process much more interesting, to try to really say, it's not about any individual tool, although I will profile people and tools and companies, because that's the way you've got to bring it to life with people and stories and anecdotes and quotes. But what are the big issues? The human in the loop issue. Are we comparing ourselves against some mythical state of perfection, or are we, as Joe Biden used to say, don't compare me to the almighty, compare me to the alternative? What are the issues in sort of how does the regulatory system work? How does this, intersect with the culture and the history of medicine and the economics and the payment system? All of that stuff, I don't think is sort of hyper dependent on what GPT you're using. And that's what made it really fun and interesting to write.
Yeah, and I think like the middle part there, like the one thing that I pulled out, which I think is really insightful and simple, which is what I like, is it doesn't need to be perfect. Like you say that a few times in the book, like about like because of what we're in, and you're so close to all of the issues we were just talking about, like just give me like a point on that where, it doesn't have to be like a perfect thing. It just has to be better than what we have today.
That's my theory of the case. So take an example. Epic just rolled out a chart summarization tool. And we can turn on a switch and it'll summarize 1 out of 5 patients' old medical record is longer than Moby Dick. That's 600 pages. If I am about to see a patient, I may have 2 minutes to review that record. Do you think I am perfect in reviewing a 600-page document in 2 minutes? It's a joke. It's impossible. It's also impossible that I could possibly keep up with all the medical literature when there are 1,000 new articles a month. So I think you have to compare it to the status quo. And in that situation, even if it's not perfect, it might be better. On the other hand, there's a logical, in some ways human tendency to hold technology up to a higher standard. How do I know that? Because Waymo has driven over 100 million miles without a fatality, and 3 months ago it ran over a cat. I'm sad about the cat too, but how many Uber drivers have driven over cats? How many regular drivers have driven? And yet it made national news. You see, I told you. And the real complexity here will be, because the incumbents may have an interest in fighting the technology, if they are worried about their jobs or their income or their status, they can take that N of 1 bad outcome and amplify it into a "see, I told you so" message. To me, that's one of the reasons I landed in a pretty optimistic place about this in healthcare, because I think for the foreseeable future, this is not going to compromise many physician jobs, if any. And, we know that because even in radiology, the radiologists are asking for AI. They're not fighting it because they see that their workload is impossible and we can't hire enough radiologists. So there's a lot of interesting dynamics that happen in the perfection or not. But I think the bottom line is it's got to be better than status quo. And if we insist on perfection, we'll never achieve that.
Yeah, and I think the reason why it resonated with me is to me that has to be back to do we have the right lens on this or not? That has to be the point of view, because my fear, this is a real fear. Let's just take the experiment going on in Utah right now. I mean, what's happening with Doctronic on some automation, also a new company, Legion, in the mental health side. If something bad hits the media that say, God forbid, somebody dies, and at the end of that, to your point of that is AI, true automation in certain states that have allowed some of these activities to move fast, that could really move us back in the use of.
I mean, I think it's happening in the mental health chatbot space where, I had a piece in the New York Times last month where basically said, yes, there have been these egregious cases of, counseling the kids to hurt themselves. And so that needs to be fixed, and it probably does need to be regulated. But on the other hand, we also have to be looking at how many, millions of people are getting what they see as useful mental health help for $20 a month. Try to find a psychiatrist in Boston or San Francisco, period. And if you can, it's $350 an hour. And so, this is just the way it's going to play out. It's why I think the lens, you have to understand the politics, you have to understand the money, you have to understand how the incumbents are going to think. And to me, I mean, one of the most interesting questions is going to be, let's say it's as good as your doctor, but cheaper and more convenient. And a new generation doesn't really have the expectation. Like, you mean I'm going to have to go to see the doctor and sit in a waiting room for 20 minutes and wait? That's crazy. So, the expectation of what care looks like may be very different as we move to a different generation.
Let's probe it. It's one of the things I really wanted to talk to you about in this discussion a little bit on this point, which is what happens to the patient-doctor relationship when we completely democratize this. We have a lot of research and a lot of stats coming out now in terms of use by consumers. Let's just start with consumers. And that changing journeys into healthcare, that changing perspectives, that changing people coming in. Like, it's no longer just the drug ads that are coming into your doctor's, hey,
Oh, no.
Dr. Wachter, I really would like this drug. Now they're coming in and say, look, I've gone through my Moby Dick book myself. And, we've seen a lot of companies starting to do that as well. So not only are companies that you talked about turning a scribe on, now there's companies coming out that the patient can have a scribe when they come in and talk to you
Right.
on their phone.
Yeah.
So the question is like, what happens to the patient-doctor relationship in all of this? And you have a lot of this, I roughly call it shadow IT. It's not really that, but you have like a consumerism movement that's happening outside the clinical episode. How does the system and how do the clinicians handle that transformation?
Yeah, I think that's going to be a massive struggle. There will be some doctors will welcome this and like the idea that their patients are informed. Some doctors will fight it like hell, believing that almost by its nature, the patient's challenging my authority. And one of the things I've told some tech companies is when they see pushback by doctors, don't assume it's the ornery geezer, the physician equivalent of, get off my lawn. It may just be, I've got 15 minutes for a visit, and you're going to come in and I've got to now dissuade you from whatever this crazy AI thing told you to do, that you need this test or that test. And that's going to take 10 minutes. And so it's just a practical matter of there's only so much time to do this, and I don't have time for this back and forth. So it's going to play out in 100 different ways. I think it's hard to predict. I think that it will be logical for many physicians to not welcome the idea that their authority and expertise is being challenged. We'll be concerned about this time sink and where we're going to find the time to have these interactions. We'll be thinking that we'll worry about this from a malpractice standpoint, that if the patient came in and AI had said to them, you should get X test, and I don't want to do it. That's kind of the moral equivalent of the patient coming in and saying, I've got a sore throat, I need antibiotics. Do you take the 10 minutes to try to dissuade them of that, or you just give them antibiotics that are not the right thing for a viral infection? In some ways, the path of least resistance is just to sort of give in. I do think what we're going to see is patients, Google says they've got 1 billion health searches a day, and we see the GPT use on healthcare. It's crazy. Patients now are going to be using these tools. The tools are not just going to be giving them a suggested diagnosis, but really suggest their care path. And so it's not going to take very long for it to suggest, you don't want to see Dr. X, he or she is not very good or is too expensive. You want to see Dr. Y or Health System Z. So in terms of not just what you need to do and what your problem is, but actually navigating your care, you're probably working with companies that are already trying to do that. That clearly is the end game here.
And do you think that becomes a serious health system business strategy problem? And so what I mean by that is if you think about all the lovely arguments and different ways we've thought about the front door to our systems, is that a way that some systems may have to lean into it in a way that's different than say they have done traditionally, where typically, everybody's come to them, the flip of supply to demand kind of flippage here.
Yeah, no question about it. I think that for a place like mine at UCSF, we've always sort of specialized in tertiary and quaternary care and the fancy stuff. And, our primary care capacity is probably 1/10 of what it could be. I get many calls a week. Can you get me a primary care doc at UCSF? The answer is often no. And the patients go to other systems. Maybe they go to One Medical and we've got an affiliated relationship. It kind of works. But you can imagine a world where patients are getting much of their care guided by AI. Either the AI is doing it or the AI is telling them where to go. And the question is there allegiance now to what the AI is telling them to do or to a system? And I think that will cut both ways. I mean, it may be that patients will not like the kind of fragmented care of the AI guiding them to this place for their CAT scan and this other place for their infusion and this other place for their primary care. Or maybe somebody can weave that together into something that feels like a coherent whole for a patient. I think for the time being, it's more likely that they're going to get their primary urgent preventative care from some NUCO that you may be funding, but still when they need fancy stuff, need to go to a system that they trust. But that may only be transient. It may be that somebody weaves together all the pieces. You say, I want the best care at the lowest cost. It says, all right, we're going to pick this from column A and this from column B, and that is not an existing system, but a system that we create virtually. I think that could go a lot of different ways.
Yeah, that to me is a real interesting area that kind of, and when I talk to a lot of the health system leaders, I talk to them often about this, which is how does this play out? You have players like CVS that are going to build a one app infrastructure to try to pull all their holistic journey together. You have OpenAI and Anthropic both trying to wedge in. OpenAI literally hosted, as you might have been there or spoke, they hosted 150 healthcare executives in San Francisco literally a month ago. And Anthropic's doing a bunch of stuff as well. And so to me, it's like that control mechanism in time. There was a research report that came out this week that said that after consumers' use of GPT, they had changed their journey profile. And most of it went back to primary care, interestingly enough, rather than going up the specialty route. So I think it's a really hot area for people to really think about at a system level.
But there's another piece that I think is important to say, which is we would normally have said, all right, yes, primary care can do a little more, but still, when they need to see a cardiologist, they need to see a whatever, that goes to a system and they're going to want to have one coherent system where the pieces talk to each other. I just wrote a piece with Bob Kocher from Venrock about the capacity of primary care docs to do more and not need a specialist. Because in many ways, AI is a specialist in my pocket. It's the curbside consult I've always wanted. The world of primary care shifts a lot because a lot of what a primary care doc does today now will be done by AI. You do not need to see a doctor to get your cholesterol managed and your blood pressure managed. So the primary care doc now has an enriched sample of complex patients because all the easy ones have been taken off their plate, but also now has capacity to do some things that they used to have to send the patient to see the hematologist, because if it's a cognitive issue, they can probably do it themselves. But you have a massive shortage of primary care docs. We're asking them to do much more complex care and operate in some ways as a generalist specialist. How does that get organized? How does that get paid? How do we get kids who want to go into that field? I think those are all very big kind of cosmic questions.
Yeah, and I love that piece that you guys put together because I completely resonated with it when I read it. Stepping maybe back here in the final couple of questions on some of these things, what do you think is the biggest misconception right now with all of this at the health system or clinical leader level?
I don't think most people understand how fast this is going and going to go and how it could disrupt the business model quite quickly. You hear people say the doctor-patient relationship is sacred. It's like my BS detector goes off. I mean, I'm a doctor. I've been doing this for 40 years. I know what it's like to tell a patient they have cancer or hold people's hands when they're dying. I mean, there are parts of it that feel really quite special, but sacred is sort of like that's designed to be a conversation ender. Like if you'd asked me 15 years ago, which comes first, all of our radiologists are fired, or I get in the backseat of a driverless car and take a nap, I would have said the radiologists are toast. So There is something about the physician role that is harder to replace than we thought. But the idea that it can never be replaced by autonomous agents or agents that largely are taking over for a big part of what physicians. I start out the book with me sitting with Gianrico Ferrugia, the CEO of the Mayo Clinic, him showing me a digital twin of a Mayo physician talking to a patient. And one of the things I said, you're obviously kind of all in on this AI stuff, but you've got the best brand in healthcare. You've got to be worried about a misstep, something goes wrong, it's going to be a huge headline. He said, I am so much more worried. The risk of going too slow is so much greater than the risk of going too fast. I don't think most leaders think that way, and I think they're going to need to. I think the advantages of incumbency, as I said, nobody's doing a liver transplant in a startup, but there's, so much of what we do, including the liver transplant, happens because patients end up in our orbit and then move through a system and get to a place like ours to their complex tertiary quaternary care. What that orbit looks like and why people, I think, are going to prefer tools that allow them to do more things for themselves less expensively and more conveniently, I don't think most people get.
I think that's well said. And I couldn't agree with you more, because I think in healthcare, as you know better than me, like, people just aren't used to this type of pace. And the leaders that we're seeing that have a technology history, like I was with one this week, it's just different when you talk to them, because they understand the pace and they understand the way they have to move versus a lot of people that are a little been historically outside of technology.
But what they all do understand is healthcare is notoriously wildly slow, even in areas where the pace is very fast outside of healthcare. So, you can value-based payment has been around the corner for 25 years. Precision medicine has been around the corner for 25 years. The digital transformation of medicine and disruption have been around the corner for 25 years. So their assumption that this is going to go slowly, even though they're using GPT in their life, but they've come by that honestly. But if you just look at, I'm sitting in my office today. If I wandered out in the wards, I would be using an AI scribe. I'd be using an AI chart summarizer. I would be using open evidence to look stuff up in ways that I used to have to call a consultant. That's happening today with tools that 3 years ago did not exist. So I think if you're awake, you're seeing a pace here that you're not used to.
Yeah, I think that's good. And interesting enough, like, regardless of the statement I said about some of the healthcare systems, the health systems, in my opinion, and it's well documented too, are moving faster than the payers, which has also been fascinating. And to your point, kind of have to, given the domains you're in and some of the things that you need. And I always say, like, a lot of stuff that we're talking about, like, it's not like these are new problems. We just happen to have a much better tech stack to start.
No, every single problem that we're addressing here, physicians aren't making eye contact with the patients. Physicians have to keep up with the literature. They've got to review a 600-page chart in 3 minutes. These are all old problems. We just didn't have a tool to fix them. And our tool until recently was, okay, we'll hire human beings. The digital scribe at UCSF did not replace nothing. It replaced human scribes. We were hiring pre-medical students at $35 an hour to do this thing. They're all gone, replaced by this technology because the technology finally could do the task.
Totally. Let's finish up with this, which is, like, what are you most optimistic about over the next 3 to 5 years? And then what worries you the most in this type of environment over the next 3 to 5?
Optimism, I think the movement toward clinical decision support is, I think scribes, chart summarizing, prior auth writing are all singles. The home run is a technology that actually can help me make diagnoses and suggest the right treatments, that's embedded in the literature and knows what the latest guidelines are. Maybe this is I think could go either way, guides me to the most cost-effective as opposed to the most lucrative treatment option. In some ways, the thing I worried about is that the pushback from probably clinicians might be pretty vigorous because the loss of autonomy there and the loss of agency will hit pretty hard for a field that, prides itself on the amount of schooling we did to become smarter than you are. And there's real tension there as these tools take over more and become, taking over tasks that we thought were really uniquely our province. What scares me the most is deepfakes. I think the idea that, the same technology that could create that Mayo Clinic digital incarnation of a doctor, therefore scaling Mayo expertise, can also be done to take a video of me and have me telling you shouldn't get vaccinated because it'll kill you, and be completely credible. I don't know how we deal with that. I'd say the other thing that scares me, just looking specifically at healthcare, is I'm very optimistic about this stuff, but it can be thrown off the rails very quickly, either by the incumbents saying, I'm now worried about this taking my job, so I'm going to push very hard on, look, I told you how unsafe this is, or it's an N of one, a really bad error that becomes sort of the cause celeb and has everybody say, you can't trust this, even though, net it's better and safer and cheaper than the alternative. I think getting those calibrations right is going to be very tricky. But overall, I landed in a much more optimistic place than I thought I would when I started. And anybody who doubts that I can write a pessimistic book should look back at the Digital Doctor. But I think for
27.
healthcare, this is going to be pretty cool. I think it's going to be good.
Well, Bob, thank you so much for taking the time. I know you're quite busy, and I would just implore you to keep writing, because I think when you write, at least when I interpret it, it's what we're all thinking, but maybe not as cogent as you usually write it. And so I really appreciate what you've done and continue to write, let alone what you do in day to day on clinical. But
Thank you, Keith.
I truly appreciate you coming on.
The feeling's mutual. I appreciate your thought leadership, and I always learn a lot from reading what you're thinking about and talking about. And it's been a great pleasure being with you.
Well, that's a wrap. Thanks so much for joining us on this episode of Healthcare is Hard, a podcast for insiders. If you want to follow Keith Figlioli, he is on LinkedIn. You can find him there at Keith Figlioli. If you want to share this podcast, make sure you copy Keith and myself. We'd love to be part of that conversation. You can find me on LinkedIn as well, Tom Salemi. You can also find me on Twitter at MedTechTom. I'm the editorial director of the Device Talks events and podcasts. So look at devicetalks.com if you're interested in the medical device field. That's it, folks. Tune in next time for another great episode of Healthcare is Hard, a podcast for insiders.
This podcast was edited by Resonate Recordings.